We wrap up Disc 1 with a discussion Sidney Smith had with Dr. Tamara Horwich, Assistant Professor of Medicine and Cardiology at UCLA, on obesity and heart failure.
Tamara, welcome to ACCEL.
Thank you for having me.
There's been a lot of interest in this sort of paradox that, as important as obesity is, sometimes people that are overweight seem to do better. So what are your observations? Can you tell the ACCEL group a little bit about what you've seen here?
Just to start from the basics, we all know that obesity is a risk factor for cardiovascular disease and a risk factor for developing heart failure. But our observations and the observations of others have been that once you develop heart failure, patients who have chronic heart failure do better with obesity, with a higher body mass index, which I can say called BMI. And we first noticed this in our advanced heart failure population back in 2001. And subsequent to that, several other studies came out, analyses of large clinical trials, even a meta-analysis of 9 observational trials, and all showing that BMI above 25 and even above 30 are associated with better outcomes in heart failure, even after adjusting for multiple risk factors.
And also adjusting for ejection fraction, I assume.
Yes. Well, it's actually been shown in both systolic dysfunction heart failure as well as heart failure with preserved ejection fraction.
Very interesting.
The same paradox.
And also waist circumference, how does that fit in if you move beyond BMI?
Right. So it's important to move beyond body mass index because higher BMI is associated with both a higher fat mass, but also a higher lean body mass. So it's not discerning between the two. So we wanted to take the next step and try to see which body composition component was perhaps lending itself to improved prognosis. And so we started measuring waist circumference in our heart failure clinic. And after we gathered enough data, we published our findings that higher waist circumference was also associated with improved prognosis in both men and women with heart failure.
Higher waist circumference.
Yes.
That is, the more they look like they have the metabolic syndrome, the better they do? Very interesting.
That was our findings. However, we did an analysis dividing our cohort by both body mass index and waist circumference. And we found, and this is preliminary because our numbers aren't as large as we'd like them to be, that perhaps those patients with a high waist circumference but a low body mass index, and that was a smaller proportion of the patients, those were the patients that were having a poorer prognosis. So in other disease states, this has been termed sarcopenic obesity. So higher visceral fat but lower lean body mass. So perhaps this is the group that may have poor prognosis, but further investigation is needed to confirm that.
Well, that would fit with the metabolic syndrome, though, the visceral adiposity for sure. Are there other ways that you can look at weight, evaluate these patients that might give more information?
Yes, there are multiple ways to try to assess body composition, ranging from DEXA scans, CT, and MRI, hydrostatic weighing. Some of these are very cumbersome techniques, but we have found a technique that we think we will be able to use in the clinic in our heart failure patients, and that is using bioelectrical impedance. This is a 1-minute test, putting a patient on a scale, and we can get an output of their lean body mass, their percent body fat, their total body fat mass, as well as their intracellular and extracellular water, which would give us a sense of their edema. That's a little added plus. Caveat was that this type of procedure was recommended not to be used in patients with ICDs or pacemakers, which of course is a large cohort of our heart failure patients. We have a publication in press right now in the journal PACE, which demonstrates that this technology, bioelectrical impedance, is safe to use in patients with ICDs and pacemakers. And therefore, I think this is going to be a very useful mechanism for our patients and for research to assess body composition in the heart failure clinic and give us a better sense of what component of body composition is important in giving us long-term prognostic information.
It's very interesting. You're a clinician. You don't just do the research. You take care of these patients.
Right.
Is there a BMI below which you really are concerned? Is there any kind of a cut point whereas you might begin to distinguish this is a patient that may well be destined for a transplant earlier rather than sooner, or an LVAD?
Yes. Definitely a BMI, just even by definition, below 18.5 is low.
Sure.
And so we know those patients were concerned, and we don't have any good studies showing what to do with those patients in terms of telling them what to do with their diet, but we always say even if you can eat small meals, eat protein, we try to get them to increase their weight. Also, we know that losing weight, we all know this, that cardiac cachexia and loss of weight over time is a poor prognostic factor. So if we have a patient who starts to lose weight, that's when we also start to get concerned. So the two, low body mass index or losing weight over time is a signal that this patient is not doing well and needs to be targeted for more aggressive therapies such as heart transplant or LVAD.
Anything short of that in terms of nutritional approaches or specific strategies for managing failure that seems to help?
Our standard heart failure therapies do help. So treating the patients with beta blockers and ACE inhibitors, analyses of studies have shown that those patients are more likely to gain some weight. So, using our standard therapies are helpful. We don't have good information beyond that. There's some smaller studies giving nutritional supplements to heart failure patients, which have shown positive outcomes in intermediate variables such as like lowering of tumor necrosis factor, increasing of body weight, but definitely larger scale studies are needed to look at how to treat these cardiac cachexic patients with nutritional supplements.
What about after transplant? I would assume that the patient with the really low BMI may not do as well as the higher. Does that pan out? Can you reach a point where you're looking at transplantation where you say, we're getting to a point with a patient here, the BMI is dropping, they're not doing well, we really need to move? And the BMI is an important part of that consideration.
Right. That's a struggle. We've always looked at our center at the patient's albumin and their pre-albumin, and that very cachectic patient we know is less likely to do well with surgery. So, in fact, sometimes you may want to consider device placement, ventricular assist device, perhaps,
right,
to get them more stabilized, to get them in a better nutritional state before proceeding to transplant. And that has seem to work at our center.
Where do you see your research going now? This is very interesting work.
Thank you very much. We are actively looking at body composition in our heart failure patients. I really want to know whether it's the lean mass or the fat mass or combination, or which combination, the components of high body mass index, which are leading to improved prognosis. And I think that will give us further information on what types of dietary recommendations we should be giving our patients. And that's where I see the future of our research.
It's very good. And one of the other sort of interesting points is thinking about ejection fraction, that falls out. In fact, my understanding is that both systolic and diastolic dysfunction are associated. You see the same relationship with obesity.
That's right.
So it's not just systolic failure.
It's not just systolic failure. It's not just diastolic heart failure or heart failure with preserved ejection fraction. This obesity paradox has also been seen in patients with acute MI, seen in hemodialysis patients, geriatric populations. So the obesity paradox is not only in heart failure, and so understanding it may be useful for multiple disease states, which affect many patients in the United States.
Tamara, thank you so much for joining us on ACCEL. We will follow your work with great interest and hope we can get you back again.
Great. So nice talking to you.
And that concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that's included as a PDF file on Disc 3. Disc 2 begins with a discussion on biodegradable polymer drug-eluting stents.